Welcome to the first webinar of the 2017. I am your host. My name is Joud Hajjar from Baylor College of Medicine in Houston. I'm going to be hosting this webinar along with my co-moderator, Dr. Monica Lawrence from University of Virginia. Today we have two great presentations and very exciting cases. The first case is going to be presented by Dr. Araceli Elizalde. She's our colleague and collaborator from the Children's Hospital of San Antonio, affiliated with Baylor College of Medicine. The second presentation is going to be presented by our very own Elena Hsieh. And we have Dr. Mike Jordan from Cincinnati moderating the first case. And Monica is going to be moderating the second case. Before we start, I'd like to thank LACID and USIDNet for their generous support of the webinar. And I would like to remind everyone to use this opportunity of this webinar to share any cases that they have any questions about. This is really a great opportunity to share cases and get input from great senior mentors. For the first case, Dr. Mike Jordan is going to be our senior mentor. But before we start, I want to remind everybody that we have a chat box, so we have the opportunity to post questions and join in for differential diagnosis by entering any comments or questions through the chat box. Without any further ado, we'll let the first case start. Araceli, take it away.
All right. Okay. Good evening, everyone. It's my pleasure to participate in the Clinical Immunology Society case webinar. And I'll be talking about a 4-year-old with enteropathy and liver disease presenting with septic shock and necrotizing. So this 4-year-old Hispanic female was admitted to the PICU on December 7th, 2016. Next slide, please. Previous one. Slide number 2. Thank you. She presented to the PICU for septic shock and necrotizing pneumonia. Thank you. The reason for consultation was for immunological evaluation due to current severe infection and past medical history of enteropathy. Just to give you a little bit of background on this child, she had been followed by GI and hem-onc as an outpatient for the past year due to multiple medical problems, including chronic diarrhea, splenomegaly, anemia, liver disease, but no previous history of recurrent infections. So when she was admitted to the PICU back in December, the GI team was the one who requested an immune consult, as they were concerned that this patient could have an immune problem or even IPEX-like type of picture. Her birth history: she was born at 36 weeks via C-section due to failure to progress, and she had a 14-day NICU stay for lung sequestration and resection. Next slide, please. I tried to change it myself, but okay, thank you. Okay, there it is. So this is a long list of medical problems for someone who's only 5 years old. And some of these some of these problems have been identified within the past year on outpatient evaluations. So she was diagnosed with failure to thrive, chronic diarrhea, or enteropathy that demonstrated partial response to gluten-free diet. On liver biopsy, she was found to have diffuse T-cell-rich steatohepatitis. She was also diagnosed with gastritis, hypoalbuminemia, cholelithiasis, and pancreatic insufficiency. She, as I mentioned previously, had been evaluated by hematology oncology due to splenomegaly, anemia, and lymphadenopathy. Cervical lymphadenopathy resolved on its own. She was diagnosed with iron deficiency anemia. Apparently, her hemoglobin responded to iron therapy. And there was no a good explanation for the splenomegaly. Can we please go back to the, I think, slide number 3? Yes, thank you. Retrospectively, reviewing her labs within the past year, she has had mild intermittent lymphopenia. Her absolute lymphocyte count has been slightly decreased intermittently. Other medical problems include malrotation, status post-repair when she was 2, and that lung mass that was removed at 14 days of age. On the family history, there was no consanguinity, no family history of PID or autoimmunity. And slide number 4, please. The physical exam, this was a small child for her age. Her weight and height were below the 3rd percentile. She was ill appearing with decreased left-sided lung sounds, subcostal retractions, and positive abdominal breathing. She was on oxygen at that time, and I examined her a few days after her admission to the PICU. Her liver edge fell 2 to 3 centimeters below the costal margin. And on the physical exam, she was not dysmorphic. She did not have any rashes, and I could not really feel any splenomegaly or lymphadenopathy. Next slide, please. And this is her chest X-ray and chest CT obtained upon admission. So on the chest X-ray, you can see a large area of consolidation on the left upper lung. And on the chest CT, you can see almost complete opacification of the left lung. There are some central perihilar region of abscesses formation or pulmonary necrosis. And in this cut, you won't be able to see, but the radiologist also reported patchy airspace opacities within the right middle and lower lobes with partial right basilar consolidation. She also had a moderate pleural effusion on the left side and small pleural effusion on the right side. Next slide, please. So this is a summary of the pertinent labs that have been obtained in this patient. Some of them were done before her current admission, and some of them during her PICU admission. So she has been found to be HIV negative. She has a normal thyroid function, normal ANA and ENCA, normal anti-RO and anti-LA. Her complement 3 and C4 levels were found to be decreased. On the celiac panel, she had elevated tissue transglutaminase and with positive HLA-DQ 0.5 and 0.8. The GI team also obtained some autoantibodies, and she was found to have elevated mitochondrial antibodies. If acting IgG was also elevated, and she had borderline smooth muscle antibody. She also had negative anti-enterocyte antibodies, but no other auto antibodies for evaluation of autoimmune enteropathy were obtained. She also had decreased vitamin A and E levels, and some of the immunological labs that we requested are listed here. So she had normal DHR testing, ruling out chronic granulomatous disease, a normal CH50, and she was found to have protective antibody titers for diphtheria, tetanus, and strep pneumotiters. And in fact, her strep pneumotiters were protected for 22 out of the 23 serotypes that were tested. Staph epidermidis was isolated from her pleural fluid. Next slide, please. Okay, so here's just to show you the duodenum mucosal biopsies. The first one was performed on April of last year. So at that time, she was found to have total villous atrophy with crypt hyperplasia and marked T-cell infiltrate consistent with celiac disease. So after that, GI put this patient on gluten-free diet, The parents report excellent compliance with the diet, and they also believe that it made a huge difference with resolution of the diarrhea. However, in November, the mucosal biopsies of the duodenum were repeated, and she still had villous atrophy with acute diffuse lamina propria inflammation, but there were no intraepithelial T-cell infiltrate at that time. Next slide, please. Okay, so here you can see the immunoglobulin profile. So the GI team had obtained an IgE level initially on December 8 that was found to be elevated. And then we advised to obtain levels for IgG, IgA, and IgM. So on December 10th, all of those came back absolutely normal. And subsequently, the patient experienced an increase, especially on the IgG, and this is without any intervention. She did not receive antibody replacement therapy. And on the lymphocyte antigen and mitogen proliferation panel, she had absent lymphocyte responses to Candida and tetanus, with low responses to PHA and CON-A, and normal to POC-WHIT. There are definitely some abnormalities there. Next slide, please. And this is to show you her lymphocyte subset panel. So there are no significant abnormalities. She has absolutely normal numbers of CD4, CD8, B cells, NK cells. And this is a CBC from last week. She continues to be anemic, but upon presentation to the PICU, she developed coagulopathy and complications from her infection. So she continues to be anemic, and she received a few PRBC transfusions shortly after her admission. The ALC was appropriate, and it fluctuates. It's not always decreased. Can you please change to the next slide?
Araceli, how about we pause for a minute and allow the listeners to join in, ask maybe any questions, and kind of help generate the differential.
Okay.
So anybody from the audience has any questions or kind of have some ideas about anything that on the differential? So we have a question. What was in the lung mass pathology that removed at 14 days of age?
Unfortunately, we don't have those records. This was reported by the parents, and it was done at a different institution. So yes, unfortunately, we don't have that information.
Okay. Do we have, I have a question. Do we have any further information about her B cells? Do we know anything about her memory B cells? And, you know, if we know anything about the switch memory versus non-switch memory B cells?
Yes. So we just got the results of the B cell panel yesterday. So she does have a decreased percentage of isotype switch memory B cells. We also obtained a FOXP3 panel, but those results are not they're not available yet.
Okay. We have a question from Dr. Notarangelo. He said, what value do you give to lack of proliferation to tetanus when the specific antibody response is protective, suggesting memory response?
Well, if there is a appropriate or normal antibody response to especially polysaccharide antigens in my mind, well, that means that there's no evidence of antibody dysfunction, and it is very difficult for me to explain why the lymphocyte response to antigen is there. Maybe it has to do with the acute infection and stress that the patient is going through during current admission. She had not been treated with any immunosuppressives at that time, but that's one of my thoughts at this point.
Okay. Was there a control that was done along with the patient for the tetanus?
Yes. I don't have the details on the proliferation results, but I'll be happy to look into those details and provide that later if it's necessary.
Sure. We have another question about whether CD40 and CD40 ligand expression was checked for this patient.
We did not check for that. We haven't done that.
Okay. And then we have another question. Do you have biopsy results of the removed lung tissue? I think that was a question that you were asked earlier as well. And you did not have any results, correct?
Yes, correct. We don't have that information, unfortunately.
Yes. We have one more question about any kind of rash or cutaneous manifestations in this patient.
No rash, no history of rashes, no rash during the current admission.
Okay. I think we're kind of ready to generate some differential diagnosis. So let's see if anybody have any ideas about a differential diagnosis for this patient. What were you guys thinking at this point? Araceli, what you guys were thinking at this point?
Okay, can I show my next slide?
Sure.
Okay, all right. So this is the list that I created before obtaining an immunological lab. So just based on the history and a physical exam, I thought that CVID was definitely a possibility. But now that we know the results of our immunoglobulin profile and the antibody titers to protein and polysaccharide antigens, we can cross this out of the list. And then down the list on the slide, I have listed different conditions that present with autoimmune enteropathy or IPEX-like syndromes. So for these conditions, well, they share the clinical manifestations of IPEX, including not only the enteropathy and autoimmune endocrinopathy and dermatitis, but the clinical findings and age of presentation are more variable, and of course, females can be affected as well. So going down the list, CD25 or IL-2 receptor deficiency. Well, the CD25 is the alpha chain of the IL-2 receptor that is expressed in Tregs and also activated T cells, and its efficiency can be associated with some of the features that my patient had, not only including the enteropathy, but infections, complications, but she did not have antigen-specific responses that were impaired, as they can be seen in patients with CD25 deficiency. In this condition also, in CD25 deficiency, sometimes they may develop profound CMV infection and increased CD8, and we did not see that with our patient. FOXP3 Tregs are expressed. We don't have results of FOXP3, so but still I kept it there because I thought this was probably a possibility. And then the next one is STAT5B deficiency. So patients with this can obviously present with autoimmune enteropathy and severe growth hormone restriction and chronic cutaneous mucocandidiasis. My patient does not have history of CMC, so I don't. She's missing many of the features for this condition. And then the next one, STAT1 mutation, it presents with polyendocrinopathy. My patient did not have diabetes or thyroid conditions, but she does have enteropathy, no dermatitis, no CMC. Patients with STAT1 can also present with fungal infections, aneurysms, some other autoimmune problems, squamous cell carcinoma has been reported. So I have it there, but your line is now unmuted. differential diagnosis is getting broad. Then the next one is LRBA mutations. So with this one, when I first reviewed the literature, it said that, you know, these patients typically present with hypogammaglobulinemia and lymphopenia. My patient does not have hypogammaglobulinemia, so I didn't really feel strong that she was going to be LRBA deficient, at least not initially. And this type of condition results from nonsense mutations. Where there is a dysfunction of a Tregs and also Treg deficiency, but they present with very similarly to my patient because they develop autoantibodies. They have this dysregulated expansion of circulating T cells. But I was missing the hypogam in this specific example. In the next one, CTLA4 mutations. These patients also present with autoimmunity, cytopenias, enteropathy, hypogam, recurrent infections, decreased B cells, so still a good option in the differential diagnosis. And the last one there is a STAT3 gain of function mutation. So again, my patient had some of the features that can be present in this condition, like lung disease, liver disease, autoimmunity, endocrinological problems, etc. So when I created this differential diagnosis list, I thought this is going to be the kind of patient that is going to need probably whole exome sequencing to be able to pinpoint where the genetic defect is located.
Sure, Araceli, if I may interject, we have some kind of other differentials from the audience that I thought I'll share with you as well. There is a NOT2, there is a CD25 deficiency, Militia Metapersky from Rome suggested LRBA, which is already on your list. There is suggestion for PI3K, RAG, and there is a question as well if there was a family history of IBD or if there was evidence of EBV infections.
No evidence of EBV infections. We tested her for that, so no, and no family history of IBD.
Okay, so we can go on so we can make sure that you get to talk about the diagnosis and the management.
Okay. Next slide, please. Okay, all right. So genetics was consulted almost at the same time that we were, and they ordered chromosome macroarray on this patient. And the results came back a few weeks ago reporting a deletion on the chromosome 4q31.3 of the LRBA gene with homozygous deletion within single exon. So we ask our geneticist to explain this a little bit more to us, and we also got input from an external geneticist. So basically, this is a biallelic mutation. Patient had one large mutation on one allele and small one on the other one, and within the large deletion, there was a buried small deletion, if that makes sense. So with the CMA technology, there is no specific, determination in terms of, what nucleotides are affected. So it's estimated that these results are highly suspicious for LRBA deficiency in view of this patient's phenotype. And this chart is just, it's a summary. I'm not going to go into detail. I'm not going to read it to you because of the sake of time. But the main high point that I wanted to make here is that most patients with LRBA deficiency present with low IgG, but not all of them, as you can see on the table. Okay, can we go to the next slide, please? So just to give you an update on the hospital course of this patient. So she deteriorated quickly after her admission and was intubated for a month. and placed on an oscillator, subsequently weaned to conventional ventilator on high pressures. But once we got the results of the chromosome microarray, we felt pressure to treat this little girl, as the consolidations from the pneumonia were treated with broad spectrum antibiotics, and after she got treatment for the pulmonary abscesses. The lung disease was not getting better, so she was still requiring high pressures, and she was left with these diffuse patchy airspace opacities in her lungs. So we started her on pulse steroids using Solumetrol, and we did a 30 milligram per kilo per dose for 3 days, followed by a very, very long taper. And we also started her on Abatacept at a dose of 20 milligrams per kilo Q2 weeks times 3. And our plan is to continue with treatment every 4 weeks. So she has received few doses of that. And because of her strong immunosuppressive therapy, we put her on prophylaxis with acyclovir, trimethoprim, and fluconazole. So her ventilator pressures have improved significantly after starting the pulse steroids. She got tracheostomy placed last week, and she is doing much better. I got an update earlier today that the patient, the sedation has been weaned. The patient is sitting up on her bed after a long time of being confined to the bed and ventilator. This is a child who coded 3 times during this hospital course. She's had a definitely very rough hospital course, but she started to show a significant improvement with immunosuppressive. So that also goes along with the diagnosis of LRBA deficiency. We're planning on doing chromosome microarray on the parents, and our geneticists, our institution, also would like to characterize the small deletion more precisely by obtaining a dedicated intragenic deletion study. And we are also in the process of obtaining flow cytometry to look for the expression of the LRBA protein.
So we have a question from Dr. Notarangelo saying that there have been reports that Abatacept or NSAID improves lung disease, but not much the GI disease in LRBA deficiency. And he's asking whether this is the case in your patient, so that her GI symptoms improve.
Well, it is interesting in this patient that at least she shows some partial response to the gluten-free diet. Now that she's been intubated and on TPN, it's very difficult to assess her GI status. I think that at some point we may need to look again at the tissue and see how she's doing after starting the steroids. That hasn't been done yet because she's had a very slow recovery and she's been very sick. But I would like to also know if anybody has had success in terms of specific treatment for some of the medical problems that this child has, like the GI, specifically the GI disease. Because as you will see on my last slide, I would like to be able to define some goals in terms of treatment and how to follow this patient long term after she leaves the PICU, and what to look for in this child, how to monitor this child long term.
Sure. So Dr. Notarangelo is suggesting using sirolimus, and I wonder if Dr. Jordan as well have any insight.
Yeah, this is Mike Jordan. Actually, Araceli, that was thanks for that thorough presentation. I have a question for you. Have you checked or been following soluble CD25?
No, we haven't, but that's something that has been done with cases that have been reported. Definitely something that we are thinking about doing.
Mm-hmm. Yeah, no, almost all these patients of this, with LRBA and inflammatory autoimmune pathology have elevated soluble CD25, and the patients that we've treated with the Abatacept and others have treated, it appears to be a pretty good marker, disease or sort of response marker, to see if, in fact, you've have suppressed some of the immune overactivation. So I would definitely recommend following that to see, now that she's off the pulse steroids, to see how that's going. You don't have a baseline or a trend to compare it to yet, but it would be reasonable to continue to follow it to see if how you're doing in terms of your dosing. But I think that the agents that I think probably should be thought about first, besides steroids, from what we know, which is very limited, would be abatacept and sirolimus. So yeah, it sounds like that she doesn't. It's hard to say that she has ongoing gut issues because you're really resting her gut. But obviously it'll remain to be seen once you actually try to use her gut again, what's going on. One thing, general question I have for you, it wasn't clear what sort of treatment had she had for her enteropathy prior to your consult? It sounds like she had pretty significant enteropathy, but was it undertreated? Was it resistant to all forms of treatment?
It is my understanding that the patient was treated with a diet for a long time, and because the parents were under the impression that there was a dramatic response, there was not much follow-up there. So the information that I have just includes that. I don't think that she was treated with anything more than the diet.
Okay, just because she was failing to thrive so much, I was wondering if they had done other things, or she broke through after some response to sort of dietary restriction. But, okay, well, and just a couple of the comments. I think your differential was very complete. I think someone else had already made the comment that RAG mutations, perhaps something in the hypomorphic SCID spectrum would be reasonable upfront to think about in the differential. The other two comments I'd have is that there are case reports, as I think you alluded to, of patients with LRBA proven deficiency that really have just isolated enteropathy without hypogammaglobulinemia, and the child's age is pretty unusual for CTLA-4, even though CTLA-4 deficiency or haploinsufficiency can give a lot of these symptoms. It's usually in much older individuals than this child, so I think that's just worth keeping in mind. But in terms of therapy, it sounds like this child's main problem is getting off the vent and out of the ICU for now. But in terms of how the enteropathy will respond, I think that you have to, I would say follow the soluble CD25, and then as you try to utilize the gut, that'll give you some better idea of whether or not the enteropathy is doing better or not. And obviously, I think your goal would be to try to avoid systemic steroids. We've treated some patients with Intercort, though that's not exactly steroid. You still get some steroid effects. It's probably better if once he's back on enteral diet, that'd be a consideration. Some Intercort, but also just things like Pentasa, just for general anti-inflammatory effects in the gut, would be reasonable to consider.
Okay.
Well, those sound like great suggestions, and that was an excellent presentation, Araceli. I think we gotta end it here to give enough time for our next presenter, Elena. So I really appreciate this presentation and Dr. Jordan's comment and everybody's comment through the chat box, and I'm gonna turn it to Monica right now.
All right, thanks very much, Joud and Araceli and Dr. Jordan. That was wonderful. We have a great case coming up next, which is a little bit more of a discussion of what do we do next in terms of treatment options, as well as a diagnostic mystery. So presenting this case, we have Elena Hsieh from the Department of Pediatrics at the University of Colorado, Denver. And as our senior mentor, we are thrilled to have Dr. Notarangelo join us from the NIH. And before Elena gets started, I think Dr. Notarangelo had a brief announcement to make regarding a funding opportunity.
Thank you. Thank you. Yeah, so Kate Sullivan has asked me actually to introduce you with the opportunity to get a one-year fellowship award from the PIDTC, the Primary Immune Deficiency Treatment Consortium. There is an award open for really any research related to primary immune deficiency, not just transplant, gene therapy, and treatment in general, but truly any research project that is specifically focusing on primary immune deficiencies. The application process is pretty easy. I just want to mention that all what is required is a 3-page research plan, a CV, a letter from your program director, and a letter from your department chair to document there are enough resources that you're given and time commitment that you can actually give to the project. If you're interested, please email Dr. Sullivan at CHOP, and she will provide additional information. Again, $25,000 direct costs, and also 8% indirect costs that are funded through the PIDTC, deadline early March. Thank you.
Great. Thank you, Dr. Notarangelo. So without further ado, so we have enough time for this case, I'm going to let Elena go ahead with her presentation.
Thank you. Can everybody hear me okay?
Yeah.
Hello? Okay.
Yes. Yeah.
So
Yep.
I will start with the history. So this was a child. He's now 14 or 15 years old. He was previously healthy, and around the age of 10 years old in 2011 had a first episode of ITP. He was given high-dose IVIG, which then completely resolved the issue. This was done by his local hospital and hematologist provider. Then 2 years went by without any issues, and in November of 2013, he had an episode of autoimmune hemolytic anemia. He had a Coombs that was positive. There was a warm autoantibody that was detected. He was then hospitalized, given Solu-Medrol, IVIG, and transfused. He did not respond to this treatment, so then received rituximab. And after 3 weeks of rituximab, then his counts recovered. And he had another 3 years in the clear. So after that, didn't go visit any doctor, had a URI in January of 2016. The parents were already cued into the issues that he has had before. So they went to the general pediatrician, checked the CBC, no cytopenias. In another 2 months, he had URI symptoms again, and at that point, the family went to see the pediatrician. He did have thrombocytopenia. The numbers were not as low as before, and they decided to wait and watch, and this episode self-resolved. Then in March of 2016, he started having fevers continuously for 2 weeks, had fatigue, had a big spleen, had 10 pounds of weight loss. And at that point, when he presented to the pediatrician, he had thrombocytopenia and anemia with a hemoglobin of 4.3, was then hospitalized. Because of the fevers, he had multiple infectious studies sent, including viral-respiratory panel, EBV, CMV, cultures, Bordetella, tularemia, Legionella, you name it. And he was started on antibiotics. They also did a chest and abdomen CT, and in the chest CT, they saw some small pulmonary nodules. So at this point, this is all happening at a outside hospital, and it is at this point when we here at Children's Hospital of Colorado, as the referral center, get a call from hematology asking us for our opinion whether they should be concerned about a primary immune deficiency. I will move on to the labs. So at this point, we are asked, and then what I asked for the hematology team to do is to draw some immunoglobulin levels, as well as vaccine responses and T and B cell subsets, mitochondrial proliferation studies, and we started getting some results back. He has an IgM of 1357, a IgG and IgA that are basically undetectable, 0 vaccine titers for tetanus and diphtheria. This is a child that has been fully vaccinated before. And then you can see the T and B cell subset that looks like this. Because the IgM was really high and there was no detectable IgG or IgA, I asked for a B-cell phenotype to further look at the B-cell compartment, and you can see that he has a very low number of isotype switch memory B-cells that are marked in the red box. Then you can see that he essentially has 0 switch plasmablast. He also had mitogen and antigen proliferation studies, and for the most part, things looked okay. He did have a low response to Con-A, but his antigen response was also a little bit low, but not absent.
Okay,
and,
Elena, before you go on. Okay, go ahead and show this one, and then we'll pause for differential after this.
Okay. Yeah, I think, let me show the last phenotyping test. So we asked for Tregs as well, and as you can see, the patient has a normal percentage of regulatory T cells.
Okay, so we have a kid with splenomegaly, pulmonary nodules, recurrent cytopenias, and then this hyper IgM and B cell class switch defect. So I will open it up to the audience. We have one question, and then I'll open it up for differential as well. So we have a question about if there are monocytes present, normal numbers of monocytes on the CBC.
Yes, I didn't show the result, but he had a normal number of monocytes.
Okay, and then Elena, just for recapping, what is your interpretation of this FOXP3 staining?
I think the interpretation
would
here
you call it
is
normal?
I think I will call it normal. I often find FOXP3 staining is not the most robust, but I think I will call it normal, especially. So I'm only showing the flow plot of the patient. I do have the one of the control, and it looks fairly similar.
Okay. And so in terms of differential, we already have one suggestion, but I encourage everyone to chime in with more. We have a suggestion for XLP or HLH. We also have a suggestion for CTLA4, keeping with the discussion from the last case.
There was also a suggestion for ALPS.
Oh, that's right. Very early there was a suggestion for ALPS, which is a great thought. And let's see, we've got the suggestions are flying in here. We've got CD40 ligand, PI3 kinase pathway, NF-kappa B, and NEMO, and some more votes for NF-kappa B and CD40 ligand. A question, two questions, and then we'll let you go on. What are the pulmonary nodules? Were those ever biopsied?
No, they were very small and not biopsiable based on discussions with radiology and pulmonary. However, he also, I'm sorry, I probably actually forgot to say that he had, along with a big spleen, he also had some large lymph nodes, including, he did have an abdomen CT, and there were some large retroperitoneal lymph nodes. He also had some large inguinal lymph nodes. So though we couldn't get the pulmonary nodules, we do have biopsy results of the lymph node as well as a bone marrow biopsy.
Okay, I think those are coming in your slides to come, right?
Yes, and I see the question here in enteropathy. He was not scoped. He, as far as we can tell, did not really have GI symptoms. He's not a child, so he's 14 and looks fairly appropriate for his age in terms of development and size. He never really had diarrhea or bloody stools, or again, based on his growth, there weren't a lot of concerns about problems with absorption, but he has never had a scope.
Okay, so a few more votes for PI3 kinase pathway defects, AID, and then we'll get one last question before you move on, which I think is important with the B cell phenotype, which was how long prior to this testing was the rituximab?
The rituximab was given 3 years before this testing. He had one round of rituximab. We do not have immunoglobulin levels pre-rituximab.
Okay. All right, so let's go ahead and move on. Show us those lymph nodes.
So this is the lymph node biopsy that we had it sent here to do staining, and you can see that there is definitely follicular hyperplasia with predominant primary follicles, which this specimen pathology basically showing that they're not polarized. There is no evidence for malignancy, and really most of the B cells were by and large IgM positive. We also asked for some CD21 IgD staining also. There was a lot of CD21 staining positivity. He had a bone marrow biopsy that showed slight hypocellularity, but pretty close to normal, and they were definitely trilineage hematopoieses. Oh, should I pause there?
Nope, go ahead. No, go ahead.
Okay.
Let's go.
So I will say that I think all the different diagnoses that have been mentioned on this, I have seen them flying in, and those are definitely all things that we were thinking about. So it shows that we can see this child has trouble isotype switching. Granted, he has had rituximab, so that definitely can cloud the picture. But if we say, okay, what are the different defects that can lead to trouble with isotype switching, they are the sort of classical hyper IgM syndromes with CD40 ligand, and I saw that was mentioned. I'll say that, as a child who's never had an opportunistic infection and never has had hospitalizations, needed any antibiotics, and was, again, growing normally until in 2011 at the age of 10 we had ITP. So, yes, to be considered, but I have to say we do not send a CD40 ligand flow assay. We also consider AID, particularly with this lymph node biopsy picture with the follicular hyperplasia, and we also consider UNG. We also thought about PI3 kinase, delta, alpha, also NEMO. In terms of phenotypic characteristics, his teeth, hair, skin, all of that was normal. What else would I say? ALPS, I didn't show it here, but we did send an ALPS panel to look for double negative T cells to Cincinnati, and that was normal. I think that covers, we did think also of CTLA4 for him. So with this, just like as a similar previous case, there were a lot of different genetic etiologies that we were contemplating. So we sent for whole exome sequencing. We did it at our commercial lab, GeneDx, with insurance coverage. And the result, the report that we got back was something like this. PKL, basically pyruvate kinase deficiency variant, Cohen syndrome, hereditary spherocytosis, and those were the only variants that they reported, either pathogenic, likely pathogenic, or uncertain significance, none of which, in our opinion, made sense in the clinical picture of this patient. And with that in mind, I had conversations with GeneDx where I specifically asked, what is the coverage? And I gave them my wish list. I said, can you comb with a fine-tooth comb the following genes, which are essentially the ones that I have mentioned just now. NEMO was the only one where they were not confident about the coverage, so actually we got that done by Sanger, and that was normal. But they assured me that it was 100% coverage for PI3 kinase, as well as CTLA4 and AID and UNG and 40 for ligand, so all the ones that were mentioned. On top of that, we asked for the raw data because if the family consents, GeneDx can share the raw data with the ordering physician, and we looked at that ourselves for those specific genes, and they came out pretty clean. I see a question, was there a microarray done along with whole exome? And the answer is no, that has not been done.
Okay, so we have
Should
a
I move on
case
to
without a genetic diagnosis. Yeah, so why don't we move on
Yep.
to your therapeutic question for us?
Yes. So here we are where basically by this point, when I got this result, so he had been discharged from that hospitalization in April, went home, which, I'm not really sure what made him better, but he did get better because we never really found an infectious etiology and his numbers recovered. He actually didn't even get steroids. He didn't get any immunosuppression. Basically, in the course of hospitalizations of about a week and a half, he improved, was discharged. At that point, we started him on immunoglobulin supplementation, and that bumped up his IgG. He started gaining some weight back again, but his counts started to drop again. His counts did actually normalize after hospital discharge, but about 4 months later, they started to drop again. And now this time, it wasn't just platelets and hemoglobin, but actually also neutrophils and lymphocytes. He started having fevers again, had abdominal pain, nausea, vomiting, and his chest CT showed a spleen of this size. And then it was at this point where I actually got the report back. I didn't have a genetic disorder diagnosis for him, so it was kind of hard to choose on a therapeutic approach. I decided to do so. One of my questions was, are these autoimmune features that we're seeing, are they either, we know that he has a B-cell switching problem, so they're probably T-cell mediated. So I got a peripheral T-cell phenotype, which was done, sent to Mayo. And then you can see that he has a significant elevation of HLA-DR positive T cells, which are fairly activated. I would imagine this occurs in the presence or either constant antigenic stimulation with either an infection or self-antigen. And we have ruled out infections pretty much. So I said, well, okay, I think at least I have a rationale for starting sirolimus because I know the T cells seem to be causing the trouble here. So we did. We did pulse him steroid-wise for, I think, 2 days, then and started him on sirolimus at the same time. And with sirolimus, things improved. So he clinically improved in the sense that he felt, because he could feel that his spleen was really large, was having a lot of abdominal discomfort. That got better. He wasn't febrile anymore. His CBC counts were holding, and as you can see on a repeat T-cell phenotype after 3 months with this therapy, the HLA-DR positive T cells have decreased in numbers. So that was a good sign. However, just very recently, probably less than a month ago, I got a call. So this family lives about 6.5 hours from here by car, so I managed them a lot from afar. And things were going okay on sirolimus. He did have a lot of mouth sores that he was unhappy with, but tolerated okay given that he held his counts. But he was admitted to the local hospital and with severe headache, had infectious studies done, had an LP done, and the communication was from the hospital there, we think he has a septic meningitis because we can't really find an infectious course. They are WBCs in the lumbar puncture. And the question to me was, could this be related to his sub-Q IG? And I think the family and the hematologist there were concerned, and I think for, yes, good reason. So the sub-Q IG was stopped, and I think because all of that was going on, then the sirolimus was also stopped. So he comes back to see me in about a week and so. He is getting a CBC repeat check this week locally, and we're going to see where his counts hold. I think I'm inclined to put him back in the sirolimus. And, if that leads to clinical improvement, I think that's great. I guess my questions to you in terms of an audience is, I have not had experience with a septic meningitis with sub-Q IG. Is this something that actually can happen? How often? And then in terms of the genetic diagnosis or functional assays, is there anything else you would pursue to help me with an underlying etiology for this family? and what
Okay, I'm
what do
going to
we
let
think
Dr.
is the long term?
Notarangelo.
Yeah.
Okay.
Yeah. So, well, thank you very much, Elena. This was a fascinating case. I have a few comments. Well, first of all, yes, I would restart sirolimus for sure. I have very rarely seen problems with like a septic meningitis on patients for patients on sub-Q. So I don't think that is the reason, and I would not hesitate actually restarting the sub-Qs. But definitely the sirolimus. I have a few comments about the diagnostic approach. I totally agree. I think it was Joud that suggested to do microarray for copy number variation. I think it is important in this case to rule out any copy number variation. The other comment I had, we discussed this about the PI3 kinase. I mean, the presentation is very much suggestive, in fact, of an activating mutation in PI3 kinase, P100 delta, or less likely P85 alpha. And you did mention actually there was sufficient coverage of the whole gene. Now, the problem, though, is that you may want to also ask about the depth of coverage. So how many reads across the gene? Because you may have that the whole gene is covered, but the number of reads could be too low, and you may actually miss, in that case, heterozygous mutations. Now, one thing we should not completely dismiss is a possibility of a somatic mutation. Some people question ALPS. Of course, there are somatic mutations in ALPS. In this case, the phenotype is unusual because you have hypogammaglobulinemia with high IgM. This is not something you often see in ALPS, but it's something to keep in mind anyhow. Just one more comment about CD40 ligand and NIAID deficiency. Again, this presentation is extremely unusual for CD40 ligand deficiency. You don't typically see very severe autoimmunity in X-linked hyper IgM. You see more of the neutropenia, opportunistic infections in hyper IgM, but not really such a severe autoimmunity. You do see that in NIAID deficiency, but the lymph node biopsy is not consistent with NIAID deficiency because those patients actually have very prominent germinal centers. I mean, now, again, like you said, I mean, the situation here is clouded by the fact that she had received rituximab 3 years before, but again, I would not expect to see only primary follicles. I would expect to see some germinal centers if this were a case of NIAID deficiency. I would consider doing a biopsy of the lymph node and repeating the exome sequencing also on the tissue and not just on peripheral blood. Just because, again, I'm always worried that there might be some somatic mutation somewhere, and it may be hidden in the tissue. In terms of treatment, I would agree, restart on sirolimus and add sub-Q. I mean, I think the sirolimus is really the key here. There was a comment about transplant, and it is true that many patients with unknown diagnosis have been transplanted, and afterwards the disease has been uncovered. Obviously, should this case present continuously with very severe autoimmune manifestations, I would consider transplant.
Yeah. And I did bring that with the family. I think my sort of, my worry, my concern is, when is the right time to consider that? He's had 3 fairly significant episodes. Am I waiting for the 4th one?
Well, you could, Michael Jordan has, again, another suggestion of CTLA-4 or perhaps LRBA. One more reason why you definitely want to look at copy number variation. You definitely want to do a SNP array for that. I think associating again abatacept and sirolimus in this case might be a good option.
Okay. Can I ask a question about PI3 kinase delta? Because I know that's been mentioned by several people. It's certainly in our minds as well. What do you think about checking for phospho-AKT?
Oh, absolutely. I would definitely do that. I would definitely do that. So, yeah, absolutely.
How robust?
It's pretty robust. It's pretty robust. Phospho-AKT, S6 phosphorylation. I mean, all of that is pretty robust. So I would definitely do it.
Okay, so even on him now, like if we drew blood from him, though he's been on sirolimus, but he's been off now for a month.
That would be fine. Yes, that would be fine. The test would be okay.
Okay.
Yeah, I agree. So, again, phospho S6K is actually even better than phospho-AKT, but both of them would be okay.
Okay, perfect. We can do that.
Let us know what happens.
Thank you.
All right.
Yeah, I will.
All right.
All right.
Thank you. Thank you, Dr. Notarangelo, and thank you, Elena, for that wonderful case. If anybody else has suggestions for Elena, you can email her. I'm sure she'd be happy to hear any of your input. And if any of you have cases that you want to present to us, just a reminder to send them to the CIS office to get advice on cases like Elena's, or to present an unusual presentation, or even just a great diagnosis.
You know, just one. Can I say just one more thing? I think Joyce actually had a very good comment. Not knowing what this is, and because of the similarities with CTLA4, and to some extent also with allergy deficiency, whenever you have neurological problems in patients like this, I think a brain MRI or a CT is absolutely warranted. So I wouldn't do just the LP. I guess that's the reason why Joyce was suggesting to do, or she was asking actually whether a brain CT was actually done at the time of the aseptic meningitis. You want to exclude that there are lymphocytic infiltrates in the brain, which is always consistent with CTLA4. Yeah.
Okay.
Yeah,
Thank
great
you.
point. Okay. All right. Thanks so much, everyone. Good night.
Bye-bye.
Thank you.
Bye.
Bye-bye.